Greetings, everybody. I'm Dr. Christy Russell, and welcome to the Product Theater, which is today sponsored by Exact Sciences Genomic Health. And so the title is Yes or No, answering chemotherapy and endocrine therapy questions through a case-based discussion with the Oncotype DX test. I'm Christy Russell, and to introduce myself really quickly, I am a medical oncologist, and my title at Exact Sciences is Senior Director of Medical Affairs. I have a former faculty position at the University of Southern California, and have been at Exact Sciences for 4 years. I have two superb physicians who will be part of the panel today. Alison Stopeck is the chief of the division of Hem/Onc and a professor of medicine at the Stony Brook Cancer Center, Stony Brook University College of Medicine. She's also the associate director for clinical and translational research for the Cancer Center. And you can read there, but she is a New Yorker through and through. She spent a little bit of time at the Arizona Cancer Center and then moved back to Stony Brook in September of 2014. And she has her research interests as there, but I've known her for multiple years as an extraordinary breast medical oncologist. Jeremy Force completed his medical degree at University of New England and his internal medicine training at Indiana, where he came under the mentorship of Dr. George Sledge, who we all know and admire well. His fellowship in medical oncology was at Duke University, and then subsequently joined the faculty at Duke, where he's currently assistant professor of medicine and breast oncology in the Department of Medicine at Duke University, and is an executive member of the Duke Molecular Tumor Board, and has his interest in both the clinical and translational care of patients with breast cancer. With regards to disclosures, you can see the disclosures from the two speakers, and I clearly have a conflict of interest or a disclosure that I am employed by Exact Sciences. So what we're going to do is we're going to present 4 cases. I'm going to present the case and want to hear from the two panelists in terms of how they view this case. We'll go through a little bit of data, and then we'll come back around at the end of the case, and we'll go through that for 4 cases. If you would like to ask questions, please type them into the question and answer queue, and we're going to take all questions at the end of the entire product theater, not related to each individual case. So let's start with the first case. It's a 71-year-old female, 1.4 centimeter, moderately differentiated infiltrating ductal carcinoma. Her malignancy is both ER and PR positive, HER2/neu is negative, and she underwent a sentinel lymph node biopsy, and her lymph nodes are negative, and she has good general health. So, Alison, tell me about how you think about postmenopausal women who are in this age range with good health and are node negative, as to whether you order a genomic assay to make a decision at this point.
In this age group, the group over 70, I definitely look at their comorbidities, what other medication she's on, and whether she would even accept chemotherapy. That's one of the first discussions I have with her. And if she would accept it, that's fine. And if she wouldn't, I want to know why she wouldn't, what she's afraid of. I also look strongly at how strong the ER is, how strong the PR is. And we get Ki-67 at my institution. And while generally I don't find the Ki-67 helpful when it's, for example, in the intermediate range between 15 and 40, I think that's all over. I think if it's clearly luminal A, i.e. the Ki-67 is less than 15%, or extremely high, like above 40%, then I look at them very differently. So if she was ER strong, PR strong, low Ki-67, clearly looking like a luminal A, I probably would just treat her with hormonal therapy and not get any genomic testing. But if any of those things were not true, I would.
Jeremy, how do you approach these?
Yeah, no, it's a similar vein. Certainly comorbidities play a role in patients who are approaching the age of 70 or older. But you know, for women who are robust, you know, those you know, athletes, women who've stayed in good shape for quite a bit of time, and or you know, their willingness to accept chemotherapy certainly play a role in ordering genomic assays. But it's similar to what Alison just mentioned. Absolutely, I have a shared informed decision-making process about whether or not a genomic assay would be right for that patient.
So an Oncotype was sent on this patient, and her recurrence score was 28. Any thoughts about that before we present some data on this topic?
Well, at 28, I would certainly recommend chemotherapy to her.
Okay.
Generally speaking, I like to be in and out, so I like to do TC times 4 in these patients. I like them to be done with their chemo as soon as possible and get onto the hormonal therapy or the radiation or what other part of their therapy. And someone of her age, depending on the chemotherapy might change depending on what her support system is. I'm also very interested in where she lives. Does she live close? Does she live close to a hospital? Does she live by herself? Does she have support? So if something does happen, like febrile neutropenia, she can get to a medical center quickly.
Jeremy, how do you think about an older patient with a recurrence score of 28?
Well, we know that women who are older, they can still benefit from chemotherapy. And I think it's important from this journey that we're honored to be a part of. When, that 5-year mark of finishing their endocrine therapy, and they look back at their journey that they've done everything possible to mitigate and decrease their risk of recurrence, it's important that the patient has a say in that matter of basically looking at what their risk of recurrence would be. And I like that with the Oncotype report that you're able to literally show them what that risk would look like on paper from a population-based perspective, and be able to have a knowledgeable conversation. I would certainly recommend chemotherapy in this patient, but I would want them to understand what that true risk of recurrence would look like with the additive benefit of chemotherapy in their specific situation. Obviously, comorbidities would play a role. And like Dr. Stopeck mentioned, I also like to try to have TC times 4 in this situation would be a very reasonable option to discuss with them so they could move on to the next steps in their care.
This is also a patient that I would definitely go to the Genomic Health website, or I guess the Exact Science website now, and do the RSPC score to get an idea what her risk of distant disease-free survival is. This is, I think, that piece of paper that gives them that exact number if they take the 5 years of AI is helpful for the patients for visualizing the benefit they would get from chemotherapy versus not.
Yeah, we'll talk about that a little bit, especially since that program is going to change after tomorrow. So just looking at the NCCN guidelines for node-negative patients who are hormone receptor positive, currently they would suggest that women who are pathologically T1 through T3 with pathologically node-negative and tumors are over 5.5 centimeters or 5 millimeters, that you strongly consider an assay. I think where this patient comes in is this issue of, because the TAILOR-X trial just randomized patients between 11 and 25, and they did not randomize the patients above that because of known chemo benefit, especially over 31. There's this gray zone of 26 to 30 where at least NCCN is suggesting that you have a choice of adding in clinical features to make the decision about chemo versus endocrine therapy, with really not great guidance about what clinical features you could consider. And so we gave her a recurrence score of 28 because I think this is still an area of uncertainty for some physicians about how to approach these patients. So let me just go on. So the original prediction data was generated from B20. This was the trial of pre and postmenopausal women, node negative, who received either tamoxifen or alone, or tamoxifen and a CMF or MF type chemotherapy. And we saw an absolute benefit from the entire trial of about 4.5%. And when we had the blocks, in green are those patients with a recurrence score 0 to 17, and yellow is 18 to 30. And we saw really all of the chemotherapy benefit sitting in those patients with a recurrence score 31 to 100, with a significant interaction between chemo benefit and the continuous recurrence score. Then the TAILOR-X trial was done, where we had this 31 to 100 clearly chemo benefit, although the interaction is for the entire score. And when they created the TAILOR-X trial, they elected to not use the 18 to 31 cut points, but instead bring it down to 11 to 25 to essentially prevent these patients who are sitting close to 31 from being randomized to endocrine therapy alone, a concern that they could be undertreated. And as you all know, the TAILOR-X trial had 10,000 patients. The mid-range, this 11 to 25, were randomized to chemo or not. These patients are pre and postmenopausal, but they are all clearly node-negative patients. You can see the stratification factors. They're different from the stratification factors from Responder that we saw today being presented by Kevin Kalinsky. And if you randomized the whole group with a recurrence score 11 to 25, there was no evidence of chemotherapy benefit for either invasive disease-free survival or for distant recurrence at 9 years. And when they did subset analyses looking at was there any other clinical feature that was related to chemotherapy benefit, and they looked at breaking the recurrence score into 3 groups, 11 to 15, 16 to 20, 21 to 25, or tumor size, or grade, or menopausal status, or clinical risk category combining tumor size and grade together. They could not see an interaction between these clinical features and the recurrence score and chemotherapy for these issues. And where they did see the interaction was a 3-way interaction between age, young age, chemotherapy benefit, and the recurrence score. So this is node negative, and just remembering this in view of the Responder data as presented today. So for women over the age of 50, with a recurrence score 11 to 25, you just see no separation of the curves. And for these node negative women, there's no chemo benefit. Whereas for women who are 50 and younger, you can see the curves starting to separate in the mid-teen region, with the straight lines here increasing chemotherapy benefit as the recurrence score is increasing for young women. And as we looked at the outcomes of these patients, these data were published in the New England Journal, adding now clinical features to the recurrence score, that we could see for women who are over the age of 50, that being high clinical risk in each of these circumstances did make the prognosis worse. So clinical features matter for prognosis. But for those patients who were randomly assigned between 11 and 25, they did not have chemotherapy benefit from the chemotherapy in that range. They just had a change in their prognostic outcome. And it is those patients with recurrence toward 26 to 100, which really bothered me a lot when we saw these data, because the node negative patients who got optimal chemotherapy and endocrine therapy, if they are high clinical risk, at 9 years, 20% of them have had a distant recurrence, knowing we need to do something different for that group. And so as Alison spoke to, we do have a tool which can be used by physicians who order through the portal, which is called RSPC, standing for Recurrence Score Pathologic Clinical Features. And so we put this patient's clinical information into that tool just to see what it would look like. And so for her recurrence score of 28, she's going to get an aromatase inhibitor. She's 71 years old, tumor size 1.4 centimeters. It's a moderately differentiated tumor. Her 10-year risk of distant recurrence is about 9%. And so I think it gives you the way of kind of really understanding what that underlying prognosis is to help guide you in terms of chemotherapy benefit. So just I'm showing this mostly also because tomorrow Joe Sperano is going to be presenting on new features of that tool, and he will be presenting on data of a meta-analysis now, including the TAILORx data, where you would be able to then use the tool online, put in the patient's recurrence score, the age, the tumor size, the grade. And now what you will get in node-negative patients is that individual patient's risk for 10 years of distant recurrence and what her anticipated absolute chemotherapy benefit will be. So it is a tool, and so invite you to listen to Joe Sperano's presentation tomorrow for refinement of that tool to not only give you prognosis, but an estimation of chemotherapy benefit. So let me go back here to this patient, 71-year-old with a recurrence score of 28. So Jeremy and Alison, kind of give me your thoughts again on that 28, how you decide in that 26 to 30 range for whom you'll offer chemotherapy. Alison, I think you might be on mute.
As you said, I think it's very helpful if there are other clinical pathologic features that help us. For example, LVI. Maybe if it's a medial tumor and we didn't look at the internal mammary nodes. Those type of things may push me more to recommend chemotherapy at 28. But in all honesty, I've had several patients in that range of 26 to 30 who says, I tell them, basically we're talking about a 2 to 3% maximum absolute benefit. And they say, no, I don't want it for that. And I think that's very reasonable. I mean, the other thing that I do in all these patients that we haven't discussed is, yes, I'm going to give you hormone therapy, but I'm also going to give you a bone-targeted agent as well, which might also decrease that a little bit, that 1 to 2% that the chemo's doing.
Jeremy, anything further on this, since NCCN has sort of a hedge on the 26 to 30 in node-negative patients? Do you think this tool will be helpful for you in specific patients in the future?
Yeah, I do. And I really am looking forward to Dr. Sperano's talk tomorrow and how that data has been amalgamated. As Alison mentioned, thinking about LVI, ER, PR status, is there a disconnect, low ER or low PR? Internal mammary lymph nodes being involved. You take the total picture together always for patients, and but still the score, which is moderately elevated, it does indicate on a population-based level that the absolute benefit from chemotherapy is not drastically large, but for some women that might be a game changer, and that 2 to 3% advantage of chemotherapy in this situation, as I mentioned earlier, along their journey, that might be important for them to look back and say, I checked that off on my box. And so, just having that discussion as an amalgamation of data, and I think to see what the discussion tomorrow, how that provides some further light on the situation will be very key.
Fantastic. All right, let me go to case 2. So we made her much younger, 40-year-old, 1.2 centimeter cancer. She's premenopausal. Her estrogen and progesterone receptor status are both high, positive. Grade 2, she's lymph node negative on her surgery, and she's in excellent health. Walk me through a younger patient and how you view in a node negative status, how you would approach considering ordering a genomic assay for decision making. Jeremy?
Yeah, sure. It's not dissimilar to somebody who's older. However, we always have, at least I have, some higher. We know that the risk of recurrence is going to increase as they get older. But again, discussing with them about the risks and benefits of chemotherapy. And yeah, we need to, we'll get to this later with our responder, but we need to, I think, really address ovarian suppression in their situation and how we can best manage that with them as a team member, and how we can make sure that that's a part of their care long term. But discussing from a chemotherapy advantage, you know, in the node negative situation, would certainly feel comfortable with the TailRx data, obtaining genomic data to potentially forego chemotherapy in this situation, but would let them know up front that that's what we're doing and the reasoning behind it. But the caveat being that we would really want to emphasize that endocrine therapy and ovarian suppression need to be a part of their care long term, and we're here as a team to help manage them, manage any toxicities or side effects that come up during the time that they're on that treatment.
Alison, is there any age too young where you would not order a genomic assay?
No, I actually think in younger patients, I want to make sure that I have as much information as possible, because in younger patients, we have the least amount of information, because those are the patients that have gone on these trials in the lowest numbers.
Mm-hmm. Right.
So I really want as much information as I can to make sure that I explore every opportunity for them to be cured. She has 40, 50, maybe even 60 years to live. So I want to make sure that I give her every opportunity to live well. And a lot of 40-year-olds, even if you know they're going to tolerate the chemotherapy, you know they're going to get through it. So I am much more looking for reasons to give them chemotherapy and giving them every opportunity for cure. So actually I order genomic testing much more frequently in younger people, and there's no lower limit that I would say, no, we don't want to order it, because no matter what, you're getting prognostic information as well, how aggressive to be with the ovarian suppression, because these are going to make a marked difference in a young person's life.
Right.
Make a tremendous difference on what they're doing, particularly if they haven't had their kids yet and want kids in the future. These things all start to come up, whether you want to do, you know, whether you want to save their eggs, their embryos. These discussions become much more common in the 40-year-old and the younger they are. So the 28-year-old with breast cancer, that's a huge discussion. She might not have had kids yet. So we need to know, so getting more information for her prognosis is so important.
So she has a recurrence score of 19. So let me just roll through these data, and we can come back on the back end of that and talk about how you would think about treating this patient. So again, 1.2 centimeter, grade 2, 40 years old. So again, from the NCCN recommendations, ASCO looks very similar. Recurrence score 0 to 25 as a group, NCCN is suggesting just adjuvant endocrine therapy. But again, as shown previously and on the left, we do know that there's some range in there where they begin to see meaningful chemotherapy benefit. And we can approach this again later, but whether it's chemotherapy benefit or ovarian suppression as a cytotoxic event or cytotoxic event on the ovaries, not the cancer, there's still a range where we begin to see chemotherapy benefit. Again, we saw originally in the original subset analysis that women, premenopausal women with a recurrence score 16 to 20 had an absolute chemo benefit of 1.6%, and 21 to 25, it was an absolute 6.5%. And I kind of saw, I'm interested in how you dealt with this on your practice, but I saw much more movement in that 21 to 25 and a little bit less pushing of the chemotherapy at 16 to 20. And then the analysis where we added in clinical features of high clinical risk versus low clinical risk for these patients. So these are in women 50 and younger, where with the recurrence score 11 to 25, high clinical risk, much more significant chemo benefit. And so this is those patients, just prognosis, not necessarily chemotherapy benefit. So the TailRx data did show that on an exploratory analysis that with recurrence score 16 to 25, there is some chemo effect, and the chemo effect is much larger in those patients with high clinical risk versus low clinical risk. We do know from TAILOR-X about a third of the patients were premenopausal, and 13% had ovarian function suppression that was given to them, and about 1,200 of them had that recurrence score 16 to 25. And when we looked at yet again another subset analysis trying to get at this ovarian suppression question, we saw that for really young women, they did not seem to get a chemotherapy benefit in that 16 to 25 range. And the chemo benefit was increasing as their age was getting closer to menopause, thinking that the chemotherapy was much more likely to shut down their ovaries the closer they were to menopause, but were clearly premenopausal. So, the conjecture is that it's ovarian suppression for this group, not chemotherapy, but you cannot prove it from TAILOR-X because they just were not stratified for that. We don't know what happened to the menopausal status from the women in TAILOR-X. And I'm just going to fly through this right back to this case. So she's 40-year-old, 19, she's low clinical risk. Tell me how you think about those subset analyses of chemotherapy benefit from TAILOR-X in this range.
Well, I think the fact that she's low clinical risk is very helpful, because when you look at the low clinical risk, less than 50, the difference between chemo and endocrine therapy alone is less than 1%. So in that group, I tend to, in this type of patient, what I tend to do is I actually usually start them on tamoxifen, and I offer them ovarian function suppression if they want to be a little bit more aggressive and do everything. So I think because I think her tumor is very hormonally driven, I think ovarian function suppression would help. And I usually start with tamoxifen so I could give, Lupron or Zoladex and see how she tolerates it. And then if she doesn't tolerate it, I stop it.
And you'll just go with the tamoxifen alone?
Exactly.
Okay. So Jeremy, for these young women and based on TAILOR-X, is there some point where you say, okay, that number's getting into the range that I want to give chemotherapy here? I don't want to depend upon ovarian suppression. The trial really didn't ask that question. Where do you feel like for sure she should be offered chemotherapy as opposed to just tamoxifen alone or tamoxifen plus ovarian function suppression? Do you have a sense about that? Do you include clinical risk? What absolute score in a 40-year-old?
Sure. No, I mean, the data from TAILOR-X is, really, I think, nicely laid out for us that, once they get into that 20 to 25 range, what happens between 19 and 20 is, a little bit up for debate. Thankfully, and as Alison mentioned, this is a low risk cancer. When you start looking into where there's a, say, like PR 20% and 80% ER positivity, you do question some of that, or if there's lymphovascular invasion, you start to look at those histologic features. But I think once you start to answer your question more directly, once you start getting into that 20 to 25 range, while the benefit is again, it's modest from my perspective. Again, some women might feel that is a significant advantage for them, and we would certainly discuss chemotherapy in that situation. And I will say, and again, I'm really looking forward to the talk tomorrow, because based on the genomic, the genes that are utilized for the Oncotype test, I mean, usually when you were to see what I just mentioned, an ER to PR disconnect or high Ki67, usually you're not going to see an Oncotype recurrence score that's in the lower range.
Right.
But that would certainly go into, from a more holistic perspective of answering your question, what we would look for in somebody who's in a younger population, and what we would potentially be discussing in terms of chemotherapy in my practice.
And what you said, Jeremy, is so true. This is where I think having tumor boards is so important, where you actually look at the slides of the patient case and make sure that the histology that you're seeing goes along with the recurrence score you're seeing. Because one of the things that I do worry about is when I get outside cases, so not from my own institution, but from the from, I don't want to say the community, that would be biasing, but from someplace else where I don't know the pathologist, I don't know what slide they sent the Oncotype from. No, I think it's really crucial that the Oncotype score comes from the most aggressive part of that tumor, so that you are taking into account the most aggressive aspect of that tumor that you want to treat.
Yeah, I agree. I couldn't agree more. I mean, it's I hear you about, you know, we're fortunate being in these academic institutions where we have subspecialized care with pathologists who focus on breast cancer pathology. I mean, we're very fortunate, and in the community, my gosh, they have so much to do, and I've seen a lot of excellent pathologists out there, but we're really fortunate in that where we can really sort of do a double check and make sure that we are indeed looking at the right stuff.
I would say that the pathologists are given directions by our lab in terms of what we feel is the most representative section, et cetera. So they are directed. And I know that whether you're in a community or not, you develop a relationship with your pathologist and you have implicit trust in your pathologist that they'll do the right thing. And so I think we never know, right? Unless we're the ones in there, you know, going through each slide and picking out what we think is most representative. Once we give over that control, we never have complete control of that question.
Tumor boards are so nice because if your biomarkers don't seem to go with your Oncotype recurrence score, obviously go back to the tumor and look at the slide and see what you see.
Yeah. All right, so let me do case 3. So this is a case, 62-year-old with a 2.4 centimeter cancer. ER and PR again are positive. It's grade 2, and she has 1 positive lymph node. She has no comorbidities. She has excellent health. So now we're into an N1 case, and I think we can talk about the responder data that were presented this morning. But again, postmenopausal. You know, she had T2 tumor, grade 2, but 1 positive lymph node. And her recurrence score is 20. So, Alison, I'm presuming that, tell me how you've approached node-positive patients in terms of ordering a genomic assay or the Oncotype score.
I have been ordering the Oncotype score, particularly when they have 1 positive node, and particularly if they have more sentinel nodes. I don't like when it's just 1 positive node, it's completely replaced, and that's the only sentinel node.
Okay.
So I look at the amount of the lymph node involved. So if it's a small amount, not like the whole node with extranodal invasion and 1 node, but if, for example, a standard 1 positive out of 3, 62-year-old with a 2.4 centimeter, so she is at high clinical risk.
Yes.
I would order an Oncotype on her and review the results. Now, before this morning, I usually used a cutoff of about 18.
Okay.
But after this morning, I mean, I think you could easily say in this patient that maybe, no, I wouldn't. I would say that I would recommend hormonal therapy alone, along with a bone targeted agent. So I'd be giving zoledronic acid 4 milligrams Q6 month too.
So let me hold you off, Jeremy, on this one, and let me just walk through the data we were dealing with up until the presentation this morning. A couple slides from the responder presentation this morning, and then really like to get your thoughts around how these data from this morning may change your approach to these patients with node-positive breast cancer. So we were, we had the data from SWOG 8814, which was a trial of only postmenopausal women who are hormone receptor positive, and they had been randomly assigned to tamoxifen alone or CAF chemotherapy with tamoxifen. So these are all node positive. It's actually any number of positive lymph nodes. So SWOG 8814 was not just confined to 1 to 3 positive lymph nodes, but they are all postmenopausal. And we did see that just like in the B20 and the node negative study, that in this prospective retrospective study, that the chemotherapy benefit appeared to be all sitting in that high group of recurrence score 31 to 100. But you can look at the numbers for the 18 to 30, right? And you only have like 110 patients or so in that group. So this is, 367 patients for the entire 8814 trial, but we were able to validate the interaction between chemotherapy benefit and the recurrence score. And as we see these data that have come through, we're having trouble seeing that interaction between chemo benefit and the recurrence score. It's because you've now removed the group of patients for whom we know there's prediction of chemotherapy benefit. And we're asking questions sort of at the lower end of the range, not at that higher end of the range. So our expectations around prediction should be modified. And so we have other data from SEER looking at 9-year outcomes. There's about 10,000 women being followed in SEER currently. And when we look at the 9-year breast cancer specific survival, for those patients with recurrence score 0 to 17, breast cancer specific survival is actually quite good, but you get into that 18 to 25 range, you can see it's starting to diminish. Clalit, which is a large registry from the Israeli Clalit medical coverage, which covers about 60% of all Israelis under that kind of medical group. We've been following 700 some node positive patients who were diagnosed between 2006 and 2011. And we saw for those patients on the left who received endocrine therapy alone, these are all node positive, if they had a recurrence score 0 to 17 and got endocrine therapy alone, at 5 years they had a 2.7% distant recurrence risk. But look at the 18 to 30. I mean, it is a worse prognosis to have a higher recurrence score. And with endocrine therapy alone, we saw almost a 10% 5-year risk of distant recurrence. So clearly, the third piece of data is the Plan B trial, where patients who were hormone receptor positive, whether they were high-risk node negative or node positive, if they had a recurrence score 11 or under, got endocrine therapy alone. And we saw that of these patients, 110 of them were node positive. We're into low numbers here. And the green are those with recurrence score 0 to 11 who are node positive. And we look at the distant recurrence on those patients with recurrence score 0 to 11, that 2% of them have relapsed at 5 years, endocrine therapy alone. So we have a lot of data now on endocrine therapy alone, but predominantly these are all postmenopausal women. So NCCN guidelines in consideration of these data, and all the genomic assays have said that node positive patients, 1 to 3 positive lymph nodes or micromets, and are candidates for chemotherapy and would agree to chemotherapy, that you ought to consider ordering a genomic assay. And specifically for Oncotype, because of those data I just quickly showed you, the recommendation was until we have the data from Responder, you might want to use a cut point of 0 to 17 in the node positive patients for elimination of chemotherapy. And if they're in the score of 18 or above, you may want to offer chemotherapy for those patients until we have the results from Responder. And NCCN here is not really commented on menopause status, although I would have to say the majority of our data to this point in the node positive patients has tended to be in postmenopausal patients. And as for those of you that were watching the presentation this morning for Responder, Kevin Kalinske presented the initial results from Responder, where we have 5,000 patients who have been randomized pre and postmenopausal to endocrine therapy alone or chemotherapy to endocrine therapy with a recurrence score 0 to 25. So anybody who had a recurrence score over 25 where we know there's increasing chemotherapy benefit are not part of this trial. And there are three interesting stratification factors. They took that 25 and broke it in half. So they looked at 0 to 13 and 14 to 25 prospectively, and they are stratified. They looked at pre and postmenopausal status and defined what that was prospectively, and then whether you had an axillary lymph node dissection or sentinel lymph node biopsy. And Alison says she's not surprised by these results, but for postmenopausal women with a recurrence score of 0 to 25, we saw no chemotherapy benefit for these node positive patients at 5 years. However, premenopausal patients at this point at 5 years have an absolute 5.2% benefit from chemotherapy if you are node positive. And when we look at what the events are for invasive disease-free survival, especially for premenopausal patients, we can see that half of those events are distant recurrence. However, in postmenopausal patients, because as you have an aging populations, you start to compete with other things. So you can see that non-breast primaries, 30% of these patients develop another cancer like lung cancer or some other malignancy unrelated to their breast cancer. And then 24% of the women have died from some cause other than related to breast cancer or her therapy. So just interesting findings, but I think the take-home message here, and we see that on the forest plot, is that for patients who are postmenopausal, recurrence score 0 to 25, 1 to 3 positive lymph nodes, any clinical feature that you look at, you are not seeing chemo benefit, including 1, 2, or 3 positive lymph nodes. No hint there that there's a greater chemo benefit with more positive lymph nodes. And including grade, low, intermediate, and high grade. No significant finding there with regards to chemotherapy benefit. On the other hand, you see a completely opposite picture in premenopausal women, and there's not a group that doesn't benefit from chemotherapy, including even the recurrence score 0 to 13 or 14 to 25. And then finally, the survival analysis that was presented this morning, suggesting even with a 5-year overall survival that there's an early showing of a survival advantage in premenopausal patients by having received chemotherapy. And nothing in the postmenopausal patient. So let me take you back to this case again. So it's a 62-year-old, 2.4 centimeter, 1 positive lymph node, grade 2, good performance status. Her recurrence score is 20. Jeremy, tell me what you thought about before with a recurrence score of 20. Did you follow those NCCN guidelines of over 18? Maybe I should use chemo. And then how you're reacting to the presentation this morning from the responder trial.
Sure. Well, I mean, I guess first of all, just to say congratulations to everyone. I mean, this is certainly a great positive finding for our patients who are especially postmenopausal, and with the RxPonder data that came out. There was lots to unpack with this presentation. I think a lot of us need to go back and look at this data again. But my first take on this and what I was doing prior to this presentation was based on the CLELET data, utilizing 18 as sort of a cutoff in the node positive setting, and having discussions with patients, obviously, about the risks and benefits. But 18 was sort of a cutoff that I was utilizing, and I was anticipating actually for this RxPonder that maybe 18 was going to be the cutoff that was noted. Not the case, and that's, I think, very positive data. I feel confident to utilize based on the data presented in the postmenopausal setting, that not necessarily offering chemotherapy, but again, discussing with them about endocrine therapy risk benefits as part of their care. We do know that endocrine therapy compliance is challenging, and I think that some of the long-term recurrences are going to be involved, from that compliance and how we can help manage that. So I think with the new data that's been updated in the postmenopausal setting, not offering chemotherapy in this situation, again, the caveat being looking at all the clinical risk features and looking forward to tomorrow's discussion. But with things standing based on the what's presented here on this slide, I think I would feel comfortable not offering chemotherapy in this specific patient.
And Alison, how did you approach these previously, and now what are your thoughts about?
I think that the presentation this morning was fantastic. Kevin did a great job presenting some, excellent data. I'm not surprised about the data. As I said, this is what I thought would happen. Because again, what happens with node positive is not that different than what happens with node negative. So the fact that in the node negative situation, postmenopausal didn't respond to chemotherapy under 25 is not surprising that in the node positive. Look at it with any other thing we do. If you're HER2 positive with no node, you get Herceptin. And if you're HER2 positive with positive node, you still respond to Herceptin. But if you're HER2 negative, you don't respond if you have node positive or node negative. So I think it's that same sort of, I look at it that same sort of biomarker that because the Oncotype recurrence score is driven so clearly by whether you're going to be hormone driven or chemotherapy responsive, it's a very good biomarker for predicting how you treat patients, whether they're lymph node positive or lymph node negative. Now, because of the strength of the data previously and how small the numbers were, particularly from the SWOG study, which was the only truly randomized study in groups over a recurrence score of 11, I've been kind of using that cutoff of 18 for my node positive postmenopausal patients. Though in all honesty, if people are very against chemotherapy and I can't convince them and they don't want to, I would go up to 25 and say, okay, we're going to maximize your hormonal therapy. We're going to do other things to improve your survival that we can do. And I was okay with not giving chemotherapy. So these results are really just very satisfying that now I feel comfortable that women who are postmenopausal with a recurrence score up to 25 can forgo chemotherapy.
So let me take you on the opposite end of that, which is not this case, but premenopausal patients, where they all seem to get chemotherapy benefit. So walk me through your thinking about those findings and tomorrow, how you will deal with this for your own patients.
That's going to be extremely difficult because when I look at the findings, when you look at the findings, you could really make a very strong hypothetical case that this is all from ovarian function suppression. We don't know that answer, but when you look at the fact that there's absolutely no difference between the 0 to 13 and the 14 to 25 with chemotherapy benefit, and in fact, if anything, the group 0 to 13 has a lower hazard ratio. And when you look at the fact that the contralateral breast cancer cases, which should not be affected at all by chemotherapy, has the same hazard ratio of 0.5. It makes you think that a lot of the benefit is from ovarian function suppression. So I think we have been underutilizing ovarian suppression in our premenopausal patients for a long time, and I think we're getting much more aware and using it a lot more frequently since the SOFTEX and even the TELEX trial. So, but with this data and this all being hypothesis generating with no real data behind it, I think that I'll be giving more chemotherapy.
Jeremy, how's your thinking about these findings? I know they just were presented to you, but in premenopausal patients, do you think that there's a population where you just feel the need from these data to just offer them all chemotherapy, or do you think that you would still consider getting the Oncotype score and at some point you would have an artificial cutoff in your head about, I think I'll just go with ovarian suppression here rather than chemotherapy? Or do you think you feel compelled to give chemo to all these patients?
Yeah, I mean, again, echo a lot of Alison's comments there. And, there's a lot to unpack with this presentation and kind of take a step back and think how this will change my practice tomorrow. Literally, I have clinic tomorrow. So in reality, I think the bulk majority of this is most likely from ovarian suppression. It's on 16% of the population had ovarian suppression in this study, which is, I think, an indication on a national level how ovarian suppression is utilized in the node positive setting, not too often. I think that needs to probably change. And in node positive patients with soft and text data, we should be recommending ovarian suppression much more aggressively. Secondly, from the chemotherapy benefit, this study doesn't answer definitively if ovarian suppression or chemotherapy is the advantage. And I do worry that there is a small, and I will say a small benefit to chemotherapy in a subset of this population that is in the premenopausal status. And I think further biomarker analysis is really required on a large scale to identify who those patients are, so we can better delineify and stratify which patients would truly benefit from the chemotherapy and not the ovarian suppression from the chemotherapy. So I think, looking back at and sort of looking how the soft and text data has played out, we know that ovarian suppression with tamoxifen or with an AI is better than tamoxifen alone in terms of reducing risk of recurrence, and pretty substantially so. So within the node positive setting, where we know that the lymph nodes aren't a barrier to developing metastatic disease, they're more of a prognostic entity, adding in the oncotype in the premenopausal setting, I think adds value. What that value is will be more of an informed discussion with the patient. I think that it's going to be challenging, and to be honest with you, I need to take a step back and look at the data, have some more conversations, and especially with patients about what that benefit is looking like. But it's looking like it's probably going to be a small benefit from chemotherapy alone. Most of it, I think, is being driven by the ovarian suppression. However, that's just my clinical take on it. This data does not definitively, this doesn't definitively answer that question.
What
Yeah,
would
we
be
can
very
spend hours talking about this topic, I suspect. Alison, your
I think
comment?
what would be very helpful is if they do the same sort of data they did in the TAILOR-X trial, where they looked at women who became postmenopausal, who were premenopausal and became postmenopausal. How did they do? Was that the group that got the biggest benefit from the chemotherapy? And what percentage of women didn't become postmenopausal afterwards? How did they do? And compare those groups.
So we are aware that more data are coming from this trial. This was just the first presentation as recommended by the Data Safety Monitoring Group. The publication is coming in the future, and we are hoping that the investigators and the SWOG Biostats group will take a look at that issue in terms of the self-reported drop in menses that occurred for women in responder. Lots more data to come, especially in the young women, that I think may, over time in the publication, help guide physicians as to how they want to think about these patients for their optimal care. So,
if I may,
okay.
Oh, sorry.
Jeremy, go.
Oh, sorry. From the, I didn't realize until the presentation that AC4 versus 6 was an analysis, and I do
TC.
Excuse me, TC. That was an analysis, and in my mind there is still some debate about TC4 versus 6, and I think analyses and that in the premenopausal setting I think would be helpful to know if there is any difference, albeit a retrospective analysis of the study. But I think that would be incredibly helpful for our patients moving forward.
I think a lot of these women who are premenopausal with 2 or 3 positive nodes, I think a lot of them are getting ACT.
It certainly would have been my practice, but my guess is still the clinical features of this individual woman were taken into account, right? How close she was to the age of 50, et cetera. So, I think there's a lot to unpack from these data, and hopefully we will get that level of detail in the publication as it comes forward in the future.
Mm-hmm.
Oh, I think there'll be many more presentations on this data.
I hope so. I hope so. For our patients, right? For them to be guided to the best therapy. But I think it's lovely that the data are out and that we're a lot more knowledgeable today than we have been in the node positive patients. And any good study leaves us with many, many more questions to be answered necessarily than those that are answered. So Really an extraordinary effort by the SWOG group, the investigators, and then the 5,000 women who agreed to be randomized in this trial. I have a fourth case, which is a case for a larger cancer for neoadjuvant. And rather than go the whole way through the case, because I'd like to get to some questions, I would like your thoughts about, do you order a genomic assay if you find that the cancer is big enough that the patient wants breast conserving surgery and at this point she has to have a mastectomy? Do you order a genomic assay? Do you use it in any way at all to make a systemic therapy decision? So Alison, I'll start with you.
This was like exactly half the cases I saw during COVID. So I'm in New York, we were hit extremely hard, extremely early. All our surgery was stopped. Every cancer patient then came to MedOnc to get some neoadjuvant therapy because surgery was stopped for 3 months, all including cancer surgeries. All of these people I was ordering oncotypes on, because luckily Genomic Health was still operating during this time, which I was very thankful for, by the way. And I was able to make, I thought, much better decisions on how to treat them. So for example, this patient with a recurrence score of 22, a 3.7 on ultrasound, I assume I will be able to palpate that as well, since I was still seeing the patients in the clinic. I would have started her on hormonal therapy in March, April, May, and June. And just followed her. I would have followed her closely. And if she didn't respond, then I would offer her chemotherapy for the lumpectomy. But the issue with her is she may not need chemotherapy. So I would prefer not to give her chemotherapy in the neoadjuvant setting when she may not need chemotherapy at all.
Jeremy, how do you approach patients where you're getting pushed into the corner by the surgeon to say, I would really like for you to shrink this cancer? It's ER positive, HER2 negative. Here, take care of this patient and send her back to me when you've shrunk things down. Do you think about using a genomic assay? Do you just tend to go towards chemotherapy? How do you approach these patients?
Yeah, well, first off, I just want to say we're thankful to have some of the some just excellent surgery team here at Duke, and it's a very collegial environment. In terms of getting genomic assays, absolutely, I would consider getting a genomic profiling in this patient to, and primarily because I want to help guide treatment decisions on whether we're going to, if for instance, let's say the Oncotype score was 39, I would certainly be offering neoadjuvant chemotherapy in that situation rather than neoadjuvant endocrine therapy. And also, I was obtaining back in the height of when this all started in March and April, I was obtaining Ki-67s and calculating PEPI scores because I thought that was a reasonable approach, especially for those women who had a lower oncotype, to really look at objective data and follow up monthly to make sure that their mass was shrinking and we were making the right choice in terms of a neoadjuvant approach. Just because, COVID was the thing that was really pushing us into or relegating us into this situation. And I had both sides of that coin where thankfully the Oncotype was up and running and we were making the right decisions for patients and providing neoadjuvant chemotherapy, albeit very scary for the patient and for me as their medical oncologist and team member, to be offering neoadjuvant chemotherapy back in March and April when we didn't know if that was the right thing, if we were immunosuppressing them to be at higher risk of developing COVID. It was very scary for everyone and still is a scary time. But I think genomic profiling in this patient is absolutely appropriate to help guide the right decisions of what we would do in a neoadjuvant setting.
So we're running towards the top of the hour. I just want to let everybody know that there are 3 sessions tomorrow that might be of interest to you. We already mentioned Joseph Sperano is going to present the RS-CLIN data, which is a meta-analysis of multiple different studies so that we can create a tool that can be used if you care to through the portal, entering in the patient's recurrence score, her tumor size, her age, and grade. Right now, this will be for node negative hopefully with the data from Responder into the future, we could reproduce this for node positive as well. And there are also 2 studies from the ADAPT trials, which are from the West German study group. One is looking at neoadjuvant chemotherapy based on what the Ki-67 does after 3 weeks of endocrine therapy with the recurrence score and neoadjuvant chemotherapy, over 800 patients receiving neoadjuvant chemotherapy, for which we'll have Oncotype on 500 or so of them. And then a trial of using the recurrence score and the dynamic Ki-67 to go to surgery and then their outcomes with endocrine therapy. So more on this topic of where does the Ki-67 play a role in helping guide decisions. So we are at the top of the hour, but we are able to stay on for another 5 minutes or so if you care to, and we can, sorry, I'm going to stop sharing this slide any second now and answer any questions that you may have. All right, so I need Tommy or Leylin, can you review any of the questions that have come through on the question?
Sure, we've been putting them in on the chat. The first one is in general, and I think you've probably covered this, is how will the Responder data presented this morning change your practice? And would the COVID pandemic influence your decision?
So good question. So Alison, I mean, we're still, we know a lot more about the virus, but we still are wildly being affected with increasing numbers. I know we went over 3,000 deaths yesterday in the United States from COVID. So this is still very much an issue now, not just for New York, but for the rest of the country. Shutting down again, etc. People with stay-at-home orders. Do you think that any of the data presented here today or at this meeting will again make you think differently about how to approach your patients during this pandemic and then afterwards?
Yes, I think the Responder data is definitely going to push me towards giving more endocrine therapy alone to postmenopausal women with node positive people. I can honestly say during March, April, May, my only patients who were hospitalized with COVID all were on chemotherapy. I didn't have anybody hospitalized on hormonal therapy. Yes, now that's a small sample size, but it was very powerful because I lost a couple of patients to COVID who were on chemotherapy who were in the adjuvant setting. So absolutely, for me at least personally, when there's this COVID crisis and pandemic, if I have a reason to give hormonal therapy or where it's clearly not going to be to the detriment of the patient, as in the neoadjuvant setting with a low recurrence score, or in the adjuvant postmenopausal setting, I'm going to be going that way.
Jeremy, how are you thinking about this? North Carolina's got its little pandemic going too now.
Yeah, it's unfortunate that it's everywhere. Exactly what Alison said. I mean, I think that the great news again for the postmenopausal setting, and that's lymph node positive. We already knew the lymph node negative situation and had the 9-year follow-up presented a few years ago. But getting these genomic profiling in the neoadjuvant setting, adjuvant setting are going to be incredibly important. There's going to be lots of discussion, lots of debate about the premenopausal patients, and I'm sure that we will require further follow-up and further analyses to help amalgamate this data for our patients and guide them with treatment decisions. But still feel very confident in the Oncotype being able to help delineate the path forward. And it's more key now than ever, now that we are pushed into these situations. And despite the vaccine potentially being available in the near future for healthcare workers and those who are in nursing homes at first rollout, this is still going to play out from a COVID perspective for several months. So this is not going away and is only going to most likely put increased pressures on us to make these decisions. And we want to make the right ones. And I think this is a way that we can help our patients out.
Did you ever avoid giving chemotherapy during the pandemic because of this issue and the concern about myelosuppression, or did you feel comfortable enough? I'll start with you, Jeremy. I'm already watching Alison's response. Do you think you avoided it in some of your breast cancer patients and went in some other direction?
So I'll say from the beginning, we didn't avoid it. I would say that the unknown was uncomfortable about whether or not chemotherapy would negatively impact them and create a more immunosuppressive microenvironment, immunosuppressive environment for them to contract COVID and have more serious events from that. And it seems that, I'm sorry, Alison, that happened in your situation. But we did not avoid chemotherapy. We haven't been avoiding chemotherapy, but I will say that I had significant pause to the effect and had some in-depth, very long conversations with patients about what the right decisions might be. But it was definitely a team decision when it came down to it about whether chemotherapy was the right decision. I think the Oncotype, a specific situation, an Oncotype of 39 in a woman who had a T1C N0 lesion, that discussion about chemotherapy, I think weighed heavily on that patient. And we moved forward, and actually she had a very good response in the neoadjuvant setting, and she has lived to see the tail, didn't contract COVID, masked and socially distanced. So I think we were fortunate that in at least the first uptick here in North Carolina, we didn't have the onslaught like we did see in your neck of the woods, Alison. And my heart went out to all of New York when that happened.
So one of the questions here is around, if you're going to, especially during the pandemic, we saw a lot more core biopsies coming in. We actually got to about 30% of all specimens coming into us were core biopsies rather than the excision. And we feel confident that the data from the core biopsy is the same that you get from excision. We have a lot of data to support that. The question is, for someone who just got started on a neoadjuvant endocrine therapy and then eventually went to surgery, they're asking the question about how reliable is the Oncotype then on a treated specimen. And I would say, just from our point of view, we will reach out to you to try to get the core. We would really like to not be testing a treated specimen because we do have a small amount of data that would suggest that the endocrine therapy for sure can influence the score. And in fact, for the most part, it looks like it makes it drift upwards because the endocrine therapy seems to be downregulating the estrogen receptor some. Even if it's downregulating the proliferative genes, we're seeing the score rise in the face of therapy. So we would go back to each of you and ask you for the core and not to send in the treated excisional specimen. So a question that was asked. It looks like that is the end of the questions. Let me just ask you one more question. If you're going to choose to go towards ovarian suppression for your patients, what is the way you approach that with your patients? Do you start in a certain way? Do you go right to oophorectomy? How do you do that to get them used to what is a really morbid procedure for them, especially the younger they are? Alison, I'll start with you.
I start with monthly, so I could see how they tolerate it. So I start with monthly, and I start them on tamoxifen, because particularly the younger they are, it's going to take them a while before they have ovarian suppression. So I think tamoxifen is much better tolerated in younger women anyway. So I usually start them on tamoxifen, and I start them on monthly Zoladex and see how they tolerate it, and I follow their side, and I see them every month to see how their side effects are. And then I go from there. And if they tolerate it well and they get tired of the injections, then I usually send them for a BSL.
Okay. Jeremy, how do you approach it for your patients?
Yeah, I mean, some of it has to be, their proximity towards menopause. So, and I think some of the data today does change that in the lymph node positive setting, at least. But prior to this data, let's say they were 50 and premenopausal, things starting them out with tamoxifen, seeing how they did over the course of that year, following up with them pretty closely, and looking at estradiol and FSH and discussing with them about their menstrual cycle to determine if they're kind of turning into a peri or a postmenopausal status. That would be one way that I've approached things. In those patients who are much younger, let's say 40, for instance, where let's just say they have children, they're not looking to have any preservation or have more children at that point. Starting them out with tamoxifen and ovarian suppression is the one way that I've kind of have them settle in, again, monthly, like how Alison has mentioned, and seeing how they tolerate that. Many patients, I will say, they do get sick of the monthly injections and they personally bring up, like, what else can we do besides this monthly injection? And we'll have discussions with them, well, listen, we're talking about 5 years, and let's say they're 43, and by the time they're over with this, they're 48. What's really those 2 years of extra potential, estrogen turning back on, or will they just have been in menopause at that point in time? And so are the ovaries essentially just vestigial organs, not really doing much for them, and they're going through this monthly injection? A BSO is pretty, it's not unreasonable, at least, to discuss in that situation. But I've seen that at least tamoxifen and ovarian suppression is a nice sort of dipping your toe into the water. Well, really, you're really getting waist deep, but you're at least seeing how they would do before you go forward with, say, a permanent BSO and going into menopause. But that's been a strategy that's worked well for many patients, and then considering switching over to an AI somewhere in between there.
So there are questions here, just a couple more. There's a question about multifocal or multicentric disease. I can tell you they were eligible on the responder trial. There's a question about how they defined premenopausal, and that will come out in the paper, but it was much more simple definition, actually, than what was given for TAILOR-X. Did responder include micromets? The answer is yes. They did, but at some point, about 2,400 patients in, they did not allow further patients with micromets into the trial to try to build out the number with more positive lymph nodes. And the final question is, if you do order a test on a premenopausal patient, because it appears if they're node positive, they all get chemo benefit, would you think about what the actual score is to go, okay, for this score, I'm going to think about ovarian suppression. When it gets above that score, I'm going to definitely use chemo. Alison, it's all being presented today, but do you think you'll be thinking in that way at all?
Yeah, I do. I do, because I tend to not want to give chemotherapy. I tend to try to stay away from chemotherapy if I can. So somebody, for example, has less than 11. I definitely am going to give ovarian suppression. I know that person is obviously going to get a huge benefit from hormone therapy. And that's the person I'll have that discussion with on whether chemotherapy might add, or, that's the data we have, but it might be a lot of ovarian suppression. And it's possible that you would get just as much benefit. We just don't have that data.
So I'd say we're in a huge data-free zone right now for premenopausal node-positive patients. Right.
The problem is these discussions are going to be extremely long now. You should just, every time you have a premenopausal woman who's lymph node positive, just
set aside more time. Okay.
That's your afternoon.
All right, so we are at time. I want to thank both of our panelists, Jeremy Force from Duke University and Alison Stopeck from Stony Brook, and just an extraordinary conversation. And I appreciate your spending your time with your thoughts, and I appreciate for those of you that dialed in. I hope this was a valuable session for you, and thank you very much for joining us today.
Thank you for having us.
Thank you.